Welcome to the deep dive. We're jumping straight into something really specific today. We've got a stack of revision notes here, all focusing on one condition, Giardiasis.
That's right. Think of this as a targeted unpacking session. Our whole goal is to go through these notes, sort of pull out the really crucial high-yield info.
You need to know.
Exactly, the stuff you absolutely need to lock down for revision, and hopefully make it, understandable and easier to remember.
So if you're maybe prepping for an exam or you just want to get your head around this particular infection, this deep dive is definitely for you. We're taking what can look like quite dense medical points and just chatting through them.
Sounds good.
Okay, let's get started then.
All right, first things first. What actually is Giardiasis? Well, at its core, it's a gastrointestinal infection.
Okay, yeah, a common starting point. But what's the specific cause?
It's caused by this tiny parasite called Giardia lamblia. It's not a bacterium or a virus, mind you. It's a single-celled organism, a eukaryote, and its favorite hangout spot, your small intestine.
All right. And what happens when it decides to set up camp there?
Yeah.
In the small intestine?
Well, its presence causes inflammation in the lining of the intestine. And it's that inflammation, that kind of irritation, that leads mostly to the symptoms you see. Things like diarrhea and just general abdominal discomfort.
So parasite gets in, inflames the small intestine, causes gut symptoms. Pretty clear chain of events.
That's the basic story, yeah.
Got it. A specific parasite causing inflammation, leading to those, well, classic tummy troubles. Now, how do you actually pick this parasite up? Where does it come from? Let's talk etiology, the cause and spread.
Okay, so the short version is you have to ingest the Giardia lamblia parasite. And the way that usually happens, the notes really hammer this home, the fecal-oral route.
Ah, yes. The one often linked to hygiene issues.
Exactly. It means tiny amounts of infected feces, which contain the parasite's tough little cyst form, somehow find their way into someone's mouth, usually through contaminated water or food, or maybe just poor hand hygiene.
Okay, so if that's how it spreads, who's most at risk? Who really needs to be aware? Let's look at the risk factors mentioned in these notes.
Yeah, the notes list quite a few, and they all tie back to that transmission route. Drinking untreated water is a big one.
Like from rivers or lakes?
Exactly, or wells that aren't properly treated. Also swimming in contaminated water. And interestingly, the notes point out that even chlorinated swimming pools aren't always completely safe from these cysts. They're quite resilient.
Wow, okay.
What else? Travel is a major factor.
Travel where specifically?
Definitely travel to regions where sanitation might not be as good, what we call endemic areas. The notes actually highlight that a lot of the cases we see here in the UK are linked to foreign travel.
Right.
Or exposure to, natural water sources like rivers or lakes, maybe while camping or hiking, even if it's not abroad.
Are there other ways, maybe less common ones?
Yeah, the notes also list oral anal contact as a transmission route. That's why male-male sexual contact is specifically mentioned as a risk factor. And then there are the more general factors. Poor sanitation overall, being in crowded places like daycare centers, or having reduced immunity that just makes you more susceptible if you are exposed.
So basically anything that increases the odds of accidentally swallowing microscopic bits of fecal matter.
Pretty much, yeah. It all comes back to that fecal-oral pathway.
Makes sense. Okay, we know what it is, how you get it. But once it's inside, what is Giardia actually doing to cause the problems? Let's get into the pathophysiology, how it works.
Right, the mechanism of mischief, you could call it. So once you ingest the cyst, it develops into the active form, the trophozoite, inside you. This trophozoite then attaches itself to the lining of the small intestine. Interestingly, it doesn't really invade the tissue deeply, but it holds on tight.
And that sticking on isn't harmless, right?
Yeah.
It causes problems.
Absolutely. That's the crucial part. The attachment itself, and just having lots of these parasites there, disrupts how the intestinal lining normally works. It significantly messes up nutrient absorption. So your small intestines struggle to absorb things properly, like fats, certain vitamins, even carbohydrates.
So symptoms aren't just irritation, they're also from things not getting absorbed correctly. Malabsorption.
Exactly. Malabsorption is a key part of the picture. And the parasite is also, quite clever about spreading. To get out and infect someone else, it forms those protective cysts again, which are then passed out in the feces.
Right, the tough little packages.
Yeah, they can survive for quite a while in the environment, like in water or soil, just waiting for the next host.
Pretty effective if nasty survival strategy.
It works for the parasite.
So, summing that up, parasite attaches, disrupts absorption, causes inflammation, leads to the symptoms we see. Thinking about it that way helps connect the dots.
Absolutely. Understanding the how helps you remember the what.
Now, if someone comes in with diarrhea and tummy pain, Giardiasis isn't the only suspect. You've got to think about other things too. Which brings us to differential diagnosis. What else could it be?
Yeah, this is a really important step. The notes suggest thinking broadly at first. You definitely consider other common causes of infectious diarrhea, your standard bacterial or viral gastroenteritis, maybe food
The
poisoning.
usual gut bug.
The usual suspects, exactly. But because Giardiasis symptoms can sometimes drag on or be a bit less sudden, you also need to think about other things causing chronic or recurring gut issues.
Like what?
Well, the notes specifically mention cryptosporidiosis, that's another waterborne parasite,
Right.
and also non-infectious causes like celiac disease or even inflammatory bowel disease, IBD.
Okay. And what if you've kind of ruled those out, but the symptoms are still there?
Then the note suggests considering irritable bowel syndrome, IBS, especially if it's chronic symptoms and you can't find an infectious or structural cause. The symptoms of Giardiasis, particularly the bloating and the change in bowel habits, can really overlap with IBS sometimes.
So yeah, you need to cast a fairly wide net, symptomatically speaking. Okay, moving on. Let's think epidemiology. Where is this most common and who gets it? We've touched on risks, but what's the bigger picture?
Yeah, building on those risk factors, the notes basically say that Giardiasis isn't that common in the UK overall, but like we said, it's much more prevalent in travelers coming back from endemic areas
Right.
or people who've had exposure to contaminated water sources.
Which loops right back to poor sanitation, travel, crowded places, low immunity, and certain types of contact.
Exactly. The epidemiology just reinforces those key risks we talked about. It's less of a general background threat in places with good sanitation and more linked to specific exposure scenarios.
Okay, let's zoom in on what it actually looks like for the person experiencing it. Clinical presentation, the signs and symptoms. What does Giardiasis feel like?
Well, it can vary quite a bit, but the most common things are diarrhea. And the notes give a really specific description here, often watery and foul-smelling.
Okay. That's a good memory hook.
It really is. Think foul-smelling diarrhea for Giardia. Often fatty, too, which we'll come back to.
Got it.
What else? Other common things are abdominal cramps, bloating, and quite a bit of flatulence. Lots of gas.
Which makes sense with the absorption problems.
Exactly. That gas and bloating come directly from that disrupted absorption we mentioned. Nausea is pretty common, too. And if the infection lingers, especially if the malabsorption is bad, people can lose weight and feel quite fatigued.
And you mentioned something about fatty stools specifically.
Yes, statorrhea. That's the medical term for fatty stools. It can happen because the parasite interferes with fat absorption, so the stools might look pale, bulky, maybe greasy, and yeah, usually pretty foul-smelling.
Because they're full of undigested fat. Makes sense.
The notes also warn that if it persists, Giardiasis can lead to longer-term problems like chronic diarrhea, ongoing malabsorption issues, and sometimes people develop lactose intolerance because the gut lining's been damaged. Untreated, symptoms can last for weeks.
Weeks. That's quite a long time to feel unwell.
Yeah.
But does everyone get symptoms?
This is a really crucial point for revision. The notes are clear. Giardiasis is often asymptomatic. Or people might just have very few physical signs.
So you could have it and not even realize.
Exactly. Or just have some mild, non-specific gut upset, which makes diagnosis a bit tricky sometimes.
Okay, so when should you specifically think about Giardiasis then?
The notes give some clear triggers. Definitely consider it if you see acute or chronic diarrhea, especially if it's gone on for more than, say, 3 days.
Right.
And it's a prime suspect in traveler's diarrhea, particularly if the symptoms are prolonged, maybe severe, if there's weight loss involved, or, crucially, if the symptoms started after the person got back from their trip.
And what about examining the patient? Anything specific to find?
Usually not much. The notes say there might be some tenderness when you feel their abdomen, but you wouldn't typically expect really dramatic signs like a high fever or a rigid abdomen, unless there were very rare complications involved.
Okay.
Most cases don't actually present with complications up front.
So it sounds like the diagnosis really hinges on the patient's story and specific tests, which leads us nicely to investigations. How do you actually confirm it is Giardiasis?
Yeah, you need proof of the parasite itself.
Yeah.
The main ways are finding either Giardia antigens, those are proteins from the parasite, or its DNA in stool samples.
And what are the specific tests they use?
Well, the traditional method is stool microscopy. That's where a lab technician actually looks for the parasite cysts or the active trophozoite forms under a microscope. But, and this is important, the notes point out its sensitivity is only around 65%.
Meaning it could miss about a third of cases. Not great if you need a definite answer.
Exactly. That's why other tests are often preferred or used alongside it. Enzyme immunoassays, EIA tests, they look for the antigens and are generally more sensitive and quicker.
Right.
And PCR tests, polymerase chain reaction, they detect the parasite's DNA by basically amplifying tiny amounts. These are also used and are very sensitive.
Did the notes mention any others? I think there were a few more listed.
Yeah, things like DNA probes, occasionally sampling fluid directly from the duodenum during an endoscopy if diagnosis is really difficult, and using special stains like methylthioninium chloride, that's methylene blue, to help see the trophozoites better under the microscope.
Now, there was a really key practical tip in the notes about collecting stool samples for suspected parasitic infections like this. This feels like something vital to remember for revision.
Yes, this is a must-remember detail. For suspected parasitic infections, the notes strongly advise sending 3 fresh stool specimens collected 2 to 3 days apart.
3 samples. Why so many?
Good question. It's because the parasite isn't always shed continuously in the feces. It can be intermittent. So collecting samples on different days significantly increases your chance of actually catching it when it's being shed.
Ah, okay. So 3 samples, 2 to 3 days apart. Got it. Lock that one in.
Definitely.
Okay, so you've done the tests. You've confirmed it's Giardiasis. How do you actually treat it? Let's talk management.
Right. The main approach is antimicrobial therapy, basically drugs to kill the parasite.
And what are the key drugs here?
The notes highlight metronidazole and tinidazole as the primary options. Tinidazole is often considered the drug of choice, partly because you can often treat it with just a single dose, which is great for compliance.
Easier for the patient.
Much easier. But metronidazole is listed as the first-line treatment according to the BNF, the British National Formulary, so you'll see that used a lot.
Okay. Are there other important parts of managing someone with Giardiasis besides the drugs?
Oh, absolutely. Vital is managing fluids and electrolytes, especially if the diarrhea has been bad. Making sure the patient stays properly hydrated, maybe using oral rehydration solutions, is really essential supportive care.
And prevention pops up again here in the management section.
It does, because part of managing the patient is also thinking about preventing spread to others. So reinforcing good hygiene, advising about avoiding dodgy water sources, that's all part of the conversation, especially for household contacts.
Makes sense. Are there alternative drugs if the main ones don't work or can't be used?
Yes, the notes mention mepicrine as another option, although it's currently unlicensed here in the UK. And mebendazole, which you usually think of for worms, apparently shows some effectiveness against Giardia too.
Okay, now here's something that really jumped out from the notes. Feels like a critical point for anyone revising this. There's a growing issue with one of the main drugs.
Ah, you mean the metronidazole resistance. Yes, this is a really key detail to be aware of. The notes explicitly state that resistance to metronidazole is increasing.
How much?
They report up to a 20% treatment failure rate with metronidazole.
20%. Wow. That's 1 in 5 cases where the first-line drug might not work. That's hugely important to remember.
It absolutely is. It means you need to have it in the back of your mind that the patient might need repeat treatment or maybe switching to tinidazole or another alternative. It also underlines why research into new drugs is ongoing.
Definitely a key takeaway. So assuming treatment works, what's the general outlook? Let's talk prognosis.
Generally, the prognosis is very good if it's diagnosed and treated properly with antimicrobials. Most people find their symptoms clear up within a few weeks after starting treatment, and serious complications are pretty rare.
But you mentioned earlier that sometimes symptoms can kind of linger.
Yes, and that's an important point the notes touch on. Even after the parasite itself is gone, some people can develop what's called post-infectious IBS.
Right.
Or just have ongoing symptoms because the gut's function has been altered by the infection. It's not the active infection anymore, but the aftermath.
What about more serious complications, though? Are there any listed?
Yeah, the notes list a few rare ones, things like failure to thrive in children, which is likely due to that prolonged malabsorption, and developing lactose intolerance because the gut lining got damaged.
Okay.
And then extremely rare complications mentioned are things like cholecystitis, which is gallbladder inflammation, reactive arthritis, and pancreatitis. But these are really uncommon.
And is it ever fatal?
The notes say deaths are rare. and usually linked to severe dehydration, especially in people who are already very vulnerable, like the very young, the elderly, or those with serious underlying health issues. But for most healthy people with access to treatment, it's not considered life-threatening.
Okay, good to know. Let's just quickly pull together the complications and prevention points that came up throughout the notes.
Sure. So the main complications, though still not super common, are the direct consequences. Dehydration, malabsorption, potentially leading to weight loss. And you could consider chronic Giardiasis or that post-infectious IBS as complications too, in terms of ongoing symptoms. The key message is that prompt, effective treatment really cuts down the risk of these things happening.
And the prevention strategies again, just to recap.
It all comes back to avoiding swallowing those cysts. So, number one, rigorous hand washing, especially after the toilet, before eating, and if you're around someone who's infected,
That's it.
then being really cautious with water that isn't treated tap water, especially when traveling, camping, or in places with iffy sanitation.
Yeah.
And remembering that note about swimming pools, even chlorinated water, isn't a 100% guarantee against Giardiasis.
Right, don't assume it's safe. What else?
Avoiding uncooked foods when traveling, especially things like salads or unpeeled fruit unless you peel it yourself. For babies, breastfeeding offers some protection. And being aware of the risk associated with anal-oral contact and using appropriate precautions.
It really underlines that this is fundamentally about hygiene and environmental exposure.
Absolutely. Understanding how it spreads is the key to stopping it.
So we've pretty much broken down these Giardiasis notes. We've covered the definition, how you catch it, how it messes with your gut, what else it might look like, who's most at risk, the key symptoms.
How to diagnose it. Remember those 3 stool samples, 2-3 days apart?
Yes. And how to treat it, including that really important point about metronidazole resistance.
That up to 20% failure rate, yeah.
And finally, the general outlook and complications.
And hopefully keeping those memory hooks in mind, like the foul-smelling diarrhea, the rule of 3 for stool samples, that metronidazole resistance figure will help you lock this down for revision. And thinking through the pathophysiology, attachment malabsorption, symptoms like bloating, gas, diarrhea, that really helps make sense of the clinical picture.
It definitely fits together when you trace the steps.
It does. So if you encounter a scenario, say prolonged traveler's diarrhea, especially if there's weight loss or significant bloating, Giardiasis should definitely be on your list of possibilities. And now you've got a solid framework from these notes on how to think about it.
Okay, well, that brings us to the end of our deep dive into these Giardiasis revision notes.
And maybe just a final thought to leave you with, drawing from the material, that increasing metronidazole resistance we discussed. It really highlights a broader challenge in medicine, doesn't it?
How so?
Well, it shows that even for infections we think we understand well, the bugs can evolve. Treatment strategies have to adapt. It means getting to full recovery or finding the best treatment first time isn't always straightforward. It's often a more dynamic process than we'd like.
Yeah, that's a really important point. Things change. Okay, well, for more help with revision, don't forget you can check out PassThemSexRed.com and also freemasetsred.com.
Great resources.
Thanks for joining us for this deep dive.